My name is Asli Heitzer. I'm a senior project manager at the Global HIV Vaccine Enterprise of the International AIDS Society. And it is my huge pleasure to open this timely topics webinar now on broadly neutralizing antibodies for the prevention of HIV acquisition in newborn and infants. And I would like to welcome all the participants, as well as our speakers and the moderator who will be introduced shortly. So this is the second of a two-part webinar series, and it was specifically curated for early to mid-career HIV researchers and advocates. And in the first webinar, we had a look at an overview of the epidemiology of HIV in newborns and infants in Central, Eastern, Southern, and Western Africa. And we also had insights into the current monoclonal antibodies R&D for the prevention of HIV. Today, we would like to contextualize this a bit, and we will discuss the scientific challenges of conducting clinical research with infants in Central, Eastern, Southern, and Western Africa. And we will also explore the acceptability and the potential policy implications of this approach. As last week, today's meeting is in two parts, and both parts will consist of two presentations each, a Q&A session and a Meet the Expert discussion. So we purposefully set this up as a meeting and not as a webinar, because we want you to engage with us. We want you to actively participate in this meeting or webinar. So please, if you have questions, raise your hand. We'll call upon you, and then you can speak or put your questions in the chat. And I would also like to inform you that this meeting is being recorded, and by participating, you agree that we will use this video publicly for educational purposes. And with that, I would like to introduce our first speaker, Tara Prasad, who is a team lead for global vaccine access at the World Health Organization, and she will present us a case study and lessons learned from the respiratory syncytial virus. I'll stop sharing, and the floor is yours, Tara.
Great, thank you so much. Let me just start sharing and go into PowerPoint mode. Perfect, thank you so much. Good afternoon, everybody. Thank you very much for inviting me to this seminar to share some insights on the work that we've been doing at the World Health Organization to better understand the global market dynamics of RSV monoclonal antibodies. My name is Tara Prasad, and I'm the team lead for the Global Vaccine Access team. So we look at vaccine access issues, including market supply, pricing, affordability, dynamics in different vaccine markets. So just to give you a bit of background about the work that we normally do, and then what's led us to develop this RSV immunization products global market study. Since 2017, we launched the Market Information for Vaccine Access Initiative, and the purpose of this initiative is multifold. It's really to help enhance the understanding of vaccine demand, supply, pricing dynamics, and then to use those findings to identify where there are access barriers and risks in specific vaccine and immunization markets. We then use these insights to convene global health partners and experts on strategies and guidance and actions that we need to take to address these identified risks. And then finally, we work directly with regions and countries to help them strengthen their capacity for vaccine supply. So we publish many different reports, and just to say that one of them is what we call our global vaccine market studies, where we're looking in a specific antigen market to try to understand dynamics occurring between manufacturers, countries, and global health partners that normally help to intervene, especially on behalf of low and lower middle income countries, to improve access. So we've actually published 11 studies since 2017, and you can see the list there, and the RSV study is underway this year. Now, just to say again that the market studies really have specific objectives, and I've already gone over what these are, but one thing I'd like to flag is that we also aim to use our findings and analysis to find where there are areas of action that either WHO or the global health community can take to improve or accelerate access once we identify barriers. Now to move into RSV specifically. So for RSV, last year we decided that there was a need for a global market study. And we decided, normally we focus on vaccines, but we decided to include immunization products, including monoclonal antibodies. So the focus of this global study is both maternal vaccines as well as monoclonal antibodies for infants. And I just wanted to give a little bit of background on, even before we started the analysis, why we selected RSV as the priority for this year. So we're quite early in the RSV market, so to speak. So products have really reached the market in the last 12 to 18 months, and there are a few products on the market with a few suppliers, but quite a broad R&D pipeline. So we know that the market is attractive for suppliers. Also, while there is RSV burden globally, a significant burden of the disease is actually in respiratory infections in infants in low and lower middle income countries. And at the same time, right now, the products are mainly being commercialized in high-income countries and upper middle-income countries. So we can see that there is still unmet need in low and low middle-income countries. And of course, because of the rapidly changing landscape right now, we're very early in the landscape, we wanted to sort of use the information we have to date to try to predict what could happen with the status quo and where we might want to do things a little bit differently to help make sure that lower middle income countries have the products that they need and that there is demand for as soon as possible. So we really were trying to find where there are risks. The other sort of questions that we wanted to evaluate were, okay, so right now, as things stand, there are some products on the market, some in the pipeline, some countries have started to recommend, register, and introduce these products, others haven't yet. What could change in the global landscape that could influence where demand and supply land? And is there going to be sufficient supply, both for the vaccine and for the monoclonal antibody, to meet the needs of all populations everywhere? And are there, as I said, actions that we should take to preempt what might otherwise be either delayed or inadequate access in populations in need? So again, just to say that right now, the market is what we call nascent, and I'll explain a little bit further what we mean by market in the next slide. Country adoption and uptake behavior is still uncertain because products have only recently become available. And with that, suppliers and their decisions on how much to allocate to which country and what pricing strategies they might set are also dynamic at this stage. And I think the last point, which I'll also go into a bit more detail in a subsequent slide, is that there are different kinds of products available targeting different populations and age groups. So that again creates a complexity because countries have different choices potentially to make. And so really, again, I think, the information that I'll share with you today is early and quite dynamic. And, we'll learn more in the coming months and years. So when I say markets and sort of market study, what we're really looking at, and again, this is based on the historic sort of dynamics that have occurred in vaccine markets, we're looking at supply. So this means how much volumes are available to which countries when, right? So it's sort of both the availability, so the volumes, the timing, and from whom, which suppliers and where are they based. And this is, of course, important because if there are fewer suppliers, then they have more ownership and there's less competition over where the supply goes. If there isn't enough supply to meet demand, then you have a constrained situation and some populations may not get the products that they need. And of course, depending on the sort of the balance between demand and supply, that could also influence the pricing of different products. On the demand side, this is sort of theoretical modeling. So we haven't gone out and spoken to individual countries and said, how much of which product do you need? And in the case of RSV mAbs, it's also too early because we're waiting for a WHO recommendation on that. But it's really based on an estimate of if these products were available and everybody could have them, what would countries think they needed potentially to have programs that targeted the at-risk populations? And so we look at sort of how much supply might be available from the suppliers either already on the market or who have products in the pipeline, and what could countries' needs be in terms of demands. So all modeled, theoretical. And then we look to see, is that in balance or not? Like, is there going to be a shortage or a surplus? And another key factor is, what sort of pricing are we looking at for different countries? And is that going to result in affordability or not? And then through that, we identify access risks related to these analyses and potential actions. And I should say that we have a standard methodology that we follow. But of course, in some areas, especially RSV, given how early the market is, we do sort of spend more time qualitatively rather than solely relying on the analyses. So then looking at the sort of RSV landscape a little bit more, so there are both vaccines and monoclonal antibodies, and they're being developed for populations across the life course. So what this means is that there are different products targeting different populations at different ages. So there's a vaccine for pregnant women, which of course in the end also is there to target newborns. There are monoclonal antibodies for infants and older infants. And so I've sort of highlighted the monoclonal antibody target populations. And then there are also vaccines for older adults and people living with comorbidities. So again, when countries, decide on their immunization programs, they have to also decide if and which products they'd like to introduce and which populations they might consider the highest risk or the most important. I think there's somebody on mute, if you wouldn't mind muting. I can hear some background noise. So what I then wanted to share with you was sort of a little bit on what insights we've garnered through doing this analysis. And just to say that right now we're about to finalize the first version of the market study. So it's not been put online yet. That will happen by the end of this month. And then, of course, very happy to share the link so that colleagues can read into it a little bit more. The study has been done based on a vast number of consultations, including with many key partners that are working in the space, such as Unitate. I see Carmen's online, so she's been involved, and consultations with regions and suppliers as well, to make sure that we get a full understanding as much as possible on what's going on and what the picture looks like. And now, again, just to share some of the specific findings that we've had that relate to the mAbs, while we've also looked at mAbs and vaccines together. And of course, that, mAbs, have a specific dynamic for RSV right now. So what we've seen is that for infant mAbs, that products are only available from 1 to 2 suppliers. And so, of course, that could limit the potential manufacturing scale up. And we see that additional products are not likely to become available until approximately 2030. And also that those suppliers are mainly based geographically in high-income countries. So that's one key sort of finding. So we've also seen that right now existing manufacturers are first responding to the demand they've received from high-income countries and low-middle-income and upper-middle-income country markets, which of course makes sense. But at the same time, we know that the health burden is high among infants in low-income countries and low-middle-income countries. So, of course, there's an unmet need there. And we did a supply and demand analysis to see, does supply meet demand? But at the same time, we were only looking at the next 10 years. And the way things are going, it seemed to us that it was unlikely in the coming decade for low and low-middle-income countries to introduce monoclonal antibodies for RSV, given the current conditions. And part of that relates to the financing availability, supply availability, and also uncertainties around country demand. And at the same time, the fact that there is an alternative product, which is the maternal vaccine, which is expected to be priced lower than the monoclonal antibodies. So we could see also that for now, the manufacturers were sort of exploring what equitable access strategies they could develop for low and lower middle income countries, and that at the same time, the supply is unlikely to reach the huge volumes like routine vaccines. And so affordability is likely to be an issue for low and low middle income countries in the short term, also just as a starting point, because the cost of goods, so the cost of manufacturing monoclonal antibodies, is higher than vaccines. And of course, price is not purely dependent on that. There could be other markups, and manufacturers can obviously add other margins. But at the same time, if the innate cost of manufacturing mAbs is higher than vaccines, then the expectation is that if the maternal vaccine is cheaper, then that might be more affordable for countries. But of course, we know that countries' decisions on products depend on many different factors and not just price alone. And so I think the other thing to note is that I already mentioned that the supplier base is based in high-income countries. And I think, following COVID, there's also been a lot of efforts to geographically diversify supply to make sure that there is more supply that is based in other regions in the world, because that results in more supply security. And I think that's also a key area to be explored for monoclonal antibodies for RSV. On the sort of demand side, I think we see that there's a potential for significant implementation challenges to deliver infant mAbs in low and low middle-income countries. And so there likely need to be investments in strengthening delivery platforms to ensure higher coverage. And then also just to say that there is an uncertainty on the potential, even if supply is available and is affordable, that the low and low middle income country adoption pace, because countries have many competing priorities and the basket of immunization products is growing. So I think that there's also to be seen to what extent RSV and related immunization products are a priority for low and low middle income countries. And all of this to say that, like many other markets of complex novel products, there is a bit of an interdependency that comes into play between supply and demand. And so what's really important is that it becomes clear to suppliers that countries want to buy or have bought on their behalf through other procurement agents products, and that suppliers in turn also ensure there's available supply and that the pricing is affordable. So this for us is really what we're suggesting as sort of a next step, is that there needs to be careful planning and balance between supply and demand for RSV mAbs as well as the vaccines. And I think I will stop there. Yes, let me stop there.
Thank you so much, Tara. That was really very insightful, connecting all of these pieces together, what leads then to the market demand. We are now going into a Q&A session with our audience, and please don't be shy. Are there any questions from the audience? Please raise your hand, put it in the chat, speak up. Let us know what your questions are.
While we are waiting for the first question, I'm sure there will be a question. I'm just going to throw a question in for Tara. The work you're describing is, and it was a brilliant presentation, is very comprehensive, but it focuses on products that do exist. So the big question is, what can be done for products that do not yet exist, and that kind of, in a way, will prepare the ground? And I see then Glenda has a question. So Tara, over to you.
Shall I come into that? Yeah, no, absolutely. Yeah. That's an excellent question. And I think, from our perspective, when thinking about access, ideally, we're thinking about early. So for products that are in the pipeline, we should obviously start to think about early access plans, because obviously otherwise you end up with a dynamic where high and upper middle income countries are served first, and then access for low and low middle income countries can be an afterthought. But for that to happen, there's almost a pathway of milestones that need to occur and need to come into place, and that need to follow the right sequence as well. So for example, I think that one of the first steps with the RSV mAbs is there will be a SAGE policy recommendation on the products for different populations. Often for low and low middle income countries, there can also be pre-qualification as a key area. But despite these, let's say, policy and regulatory pathways, even before that, we can start to engage with manufacturers and discuss with them what their plans are, try to give some early signals on demand, and also try to obviously negotiate access plans and access strategies to make sure that those are already baked into manufacturers' investments and plans. And obviously, and we've seen in other vaccine markets, there have been a lot of investments, both to support the R&D So donors give money to help, so, as we'd say, de-risk the R&D for certain products. And also donors make firm commitments on how much they will end up buying on behalf of low and low income countries. So of course, there are interventions like that. But I think also, we know with RSV MAbs that there is a commercial market for the suppliers. So they know that this makes business sense. So I think the question is, how do we also make that business case extend to low and low middle income countries? And actually, the Gates Foundation has invested very early in a MAb that's in phase 1 to help support that. So we are hoping that global health partners will start to think about how they can help support the pathway to access, similar to what's been done for many, many vaccines. Thanks.
So thanks very much for a wonderful presentation, Tara. I'm Glenda Gray from South Africa. I just wanted to know a little bit about, you didn't give us really the cost of goods and maybe the variation, and also exactly what the demand is at the moment in high middle income country settings, to try and understand how one can focus on a more global market, and as well as the advocacy, besides recommendations from SAGE, but the kind of steps to actually realize this access in low middle income country settings going forward. Thanks.
Yeah, thanks so much. So, for the cost of goods, there are many studies that estimate, but we've seen that they could range to almost, 100 times the cost of goods of vaccines, for example. So that just gives you a sense of where it could lie. And I think that we because the products are not being sold yet in low and low middle income countries, we've been trying to look at what prices are available. And we've seen a price range for RSV MAbs from about $400 to $520 per dose. And of course, at the same time, we know that quite often there'll be sort of tiered pricing structures that allow discounts for low and low middle income countries. And we've heard indications of that. So the price point is yet to be seen. But of course, I think it's important to be aware and to think about how this will play out in the long term. And sorry, I forgot the second part of your question.
The advocacy or lack thereof to ensure that there's no, there's essentially what you're saying, there's market failure in the low and middle income country settings, and all we should do is worry about getting maternal RSV vaccination, whereas there's obviously different playing fields for the rich and the poor, and the haves and have-nots.
Yeah, no, absolutely. And that's exactly a concern, that you'd end up with a sort of dual segmented market. And obviously what you'd want is that countries that have a need and have demand for the different products have access to them, and then that those conditions are materialized in a way that makes it possible, including affordability. I think so. Absolutely, our the SAGE recommendation will obviously help create the pathway, but our market study is intended really to advocate. So it is, from WHO's perspective, we want to sort of bring attention to the different issues there, bring an early light, shine a light on the challenges, and then also suggest actions that stakeholders can take, so that we don't end up with the picture that you painted that could become a reality. And so from our side, of course, once we publish the study, then we also try to work with the different players in the field to make sure that the conditions improve. And I was also wondering, Roger, if you wanted to say a little bit about the overall MAb body of work the WHO is doing, because I think that's also a broader advocacy piece.
So you're putting me under the, sorry, no, I'm on that. So you're putting me under the spotlight here, but it's true. I also work for the WHO, and the WHO is currently looking at access to monoclonal antibodies in general, both for non-communicable disease and infectious disease. And the aim of that separate project is really for the WHO to build a common position across the different units of the organization along the product development path, from research to implementation and rollout, and send out a list of recommendations and describe a roadmap that would support increased and more equitable access to monoclonal antibodies. We have three questions. I'm going to do them in order. The first one, I think I've been in part responded, was from Betsy McFarland asking, can you say more about what information is used by country in choosing what health intervention to make a standard in this context? And then we'll go to you, Luzine, and then to Carmen.
Yeah, thank you so much. That's actually a great question, and also an area we've identified for action, actually, is improving a comprehensive evidence base to support both increased awareness by countries and also inform their decision-making product choice. And I think, for example, some of the analyses that we've called out are the impact of RSV-related disease and all-cause lower respiratory tract infections, cost effectiveness of different products is another key one, and also of delivery strategies and the cost of illness of RSV. So I think there are still some analyses that need to be done. In our engagements with different regions, we could really see a variation in terms of the level of both awareness and priority was currently assigned to RSV. And we also looked at, I think, countries' immunization, prioritization of influenza as an example, although there isn't a perfect proxy there because of the burden of disease of influenza, which is different. So there certainly is more information that countries need. One of the things that we're doing actually at WHO, and it's also being led in my team, is developing what we're calling a compendium of evidence to inform country decision-making. We'll be doing this, including for RSV, where we bring together the different pieces of information to support countries in their decision-making on product introduction or even sometimes switching between products. Obviously part of it is what the policy recommendations are, what the different product availability is, what's on the market, what's coming. Price is one factor, but also, again, cost effectiveness and sort of value for money as well. Thanks.
Thank you. I'll go to Luzine Kazarian from USAID if you want to come up.
Yeah, thank you very much, Roger. And thank you very much, Tara, for a great presentation. My question is if you have considered potential subsidization of RSV monoclonal antibodies by high-income countries to assist low and middle-income countries, in decreasing or mitigating their access risks or helping with supply-demand balance. Any thoughts on that, please? Thank you.
Thank you. That's a great question. And I think that, in conversations with manufacturers in general on vaccines, there's sort of the assumption would be that that's sort of how tiered pricing might work, that some of those subsidies are baked in. So I think that could be a good starting point. At the same time, we also know that sometimes tiered pricing doesn't result in affordability, especially for sort of middle-income countries. And then you have other models like in the immunization space where you have Gavi, the Vaccine Alliance, that will provide a co-financing. So they'll sort of subsidize the price of the product so that countries only pay for some of it for a certain number of years, depending on the country's income level as well. And then eventually when the country has adequate budget. So of course, there are models out there that I think can and should be explored for monoclonal antibodies. And of course, it's also possible that this RSV monoclonal antibody could be included in an investment case by Gavi. So I think that, yes, absolutely. I mean, in the end, if there is a global market between high-income countries and higher income and low-income countries, then it does make sense, and it can make a good business case.
Thank you. Our final question for this session, but there will be opportunity for more questions after the next presentation, is from Abduli Jallo. Over to you.
Good afternoon. My question is looking at the risks of protection, like the fading of the protection over time. What is the plan for the premature born babies?
So if I understand the question correctly, you were asking for whether the sort of premature babies could have access to the MAbs?
Yes, yes, because looking at the the risks that over time the protection can fade away, because as it only provide passive immunization. So what is the plan for the premature babies? Yeah.
Yeah. So I think that for the current monoclonal antibodies, they're for children of less than 1 year old or entering their first RSV season. And I think that obviously in some countries, they might choose to prioritize high-risk children with the products.
Thanks a lot, Tara. Thanks a lot for the questions from the audience. And I would like to hand over now to Enele. Enele is part of the community working group in Chatsworth, South Africa. And she's gonna talk to us about the acceptability of bNAbs for newborns and infants. And Enele, I'm gonna project the slide for you and you just prompt me to move whenever you're ready.
Sure, thank you so much. Greetings, everyone. As I've been introduced, my name is Enele Zulu. I work for the Center for Community Impact, and I'm also part of the community working group with the South African Medical Research Council. So I'm really excited to present to you on a topic that holds immense potential for advancing the fight against HIV transmission on newborns and infants. That is the acceptability of bNAbs for protection. Can you move to the next slide, please? Okay, so my presentation will really highlight and explore the current community of practice landscape, the potential of benefits, and also highlights the key considerations surrounding the use of bNAbs, which is for the vulnerable population, the newborns and the infants. And just to also highlight, I'm also a mother. Yeah, that's why I am part of this session today. If you can move to the next slide, please. Okay, just zooming in on the prevalence of HIV in South Africa. So South Africa remains one of the countries with the highest recorded number of people living with HIV, and this accounts for the majority of new pediatric transmission. So with this data in mind, I'm just going to draw on the community lens and our responses. So high teenage pregnancy in the community. There's also high teenage pregnancy in schools and universities. And we also have high transmission on young mothers. So there was a survey that was conducted on HIV prevalence, and the data showed that females continue to be disproportionately affected by HIV, with a prevalence of 16.4 compared to males. However, through these challenges, there are various HIV interventions contributing or contributing to government efforts, which is the Global Alliance to End AIDS on Children. So our responses as a community working group in the community on the acceptability of bNAbs by the community through the implementation science. So as HIV clinical research on newborns and infants remains critical for advancing our understanding of pediatric HIV and improving outcomes for this vulnerable group. So amongst our responses, we've held community working group meeting where bNAbs, which is the pediatric study, was presented. So during these engagements, members were really concerned about infant safety and well-being, since this was a phase 1 clinical study. They also concerns also centered around the efficacy of the bNAbs on newborns and infants. So as we know that bNAbs have proven to work on adults, and one of the skepticism remained if they would work on newborns and infants as their immune system yet developed. So there were also cultural concerns towards norms, towards values, towards morals. For example, in our African cultures, newborns are prevented from external exposure for a period of 3 months. So it was important for an early intervention, which was required for newborn and infants, as they are vulnerable to HIV transmission during birth and breastfeeding. There were also concerns around cultural practices or ritual performed on newborns, such as the preference over traditional medicines, over Western medicines. So there were. Can we move to the next slide? So there were further community engagements, which was focused on the sensitization and education towards integrating those cultural norms. We also conducted education for both service providers and mothers on the acceptance of bNAbs. So it was really important for us to have that cultural sensitive communication, which tailored on strategies to the cultural background, and also the use of language, and also share information that would really be understandable for the mothers. So community members and families of those living with HIV were also engaged. They were sensitized and educated on the clinical trial prior to their HIV disclosure. So this really yielded acceptance on those living with HIV. So there was also an achievement on the targeted enrollments on the bNAb studies, and there was also 100% retention rate to those who have enrolled. So most of them came with their partners, they came with their grandparents and other family members. Some would also, request family education. And there was also community education sessions on bNAbs, which targeted community healthcare workers and community health service providers. Building trust for us was also very crucial and imperative. We've engaged community health workers, local leaders, and also trusted individuals within the community to facilitate these discussions for us and provide information on the clinical trial. Next slide. One of the challenges that we have been able to overcome was the lack of HIV disclosure to partners and family members. So most mothers struggled with disclosing their HIV status. So being part of the clinical trial alone was a predicament for them or a challenge for them. However, we had to engage and have that psychosocial support and build that trust with them, so they're able to disclose their HIV status to their families in order for them to also participate freely on the trial. And we also encountered discrimination and stigmatization on HIV and AIDS. There were also misconceptions on the HIV transmission and other beliefs to treat HIV. So as a mother, my perspective is that I believe that the use of bNAbs for newborns and infants is not only acceptable, but also potentially life-saving for, infants. Yes, there are and maybe concerns about the potential side effects, as we've also encountered as with mothers who were concerned about the child's vulnerability. What are the risks? The questions that they would ask is, what are the risks for them to participate and for the bNAb to administered on their infants? However, they also focused on the harm and danger of the bNAbs. However, HIV is a deadly disease, and protecting children is top priority, and that is what was the message that was really conveyed to mothers to get them to be involved in these clinical trials. I also have faith in medical research and the technologies that have led to the development of bNAbs. So we do have supportive team who are part of and field workers who are part of these clinical trials. They're able to translate evidence to us, for us to understand it, and for us to actually translate the same evidence and data to the community, building trust, and for them to participate freely. By giving bNAbs a chance, we can give our children a chance to a healthy HIV-free future under the hashtag that no child deserves to be born with HIV. So just to conclude on my presentation, continued investment on research, conducting capacity building to the community, and engaging community is essential to address the unique challenges faced by the infants and newborns affected by HIV or who are born out of HIV positive mothers. There is also hope for the community, for the nation, and the world through continued support of bNAbs on pediatric HIV prevention. bNAbs also have proven to be safe, have great efficacy, and have ethical consideration as mothers are informed on administering bNAbs on their newborns and infants. So I believe that involving mothers to accept bNAbs requires a multifaceted approach that addresses their concerns, their challenges, and also their needs. So that will come to the end of my presentation. Thank you.
Thanks a lot, Enele, for presenting us the perception, but also the challenges that you were facing, or not you were facing, but the implementation of bNAbs.
Yes.
And I would like now to open our Meet the Expert session, and I also owe Roger a formal introduction because he has already helped out. He is the moderator for the Meet the Expert session. He is working for Eugenia Consulting and helping us. And Roger, over to you.
Thank you very much, Ashley, and no problem at all. We have 2 minutes extra, and I'm gonna take this while people put their question into the chat or raise their hand. A direct question to Enele in terms of, in the discussion with mothers and the use of bNAbs, was there any discussion around preferences, and in particular comparing the use of bNAbs versus the use of ARV or in different formulation? But was that something discussed?
Sorry, can you please repeat the question?
Yes, no
We are
problem.
breaking up it.
Was there discussion with the mothers about their preference in terms of intervention? For example, monoclonal antibodies, like you discussed, versus antiretroviral?
Yes. We did have, as I've indicated, we had experts of researchers, we had field workers within the institution. So, you know, they were able to provide comprehensive information. They've offered detailed information about the clinical trial, including the study protocol and the benefits of the bNAbs. So yes, that was discussed. Although yes, some of the matters are under odds. However, they also had preference over the bNAbs if they are safe. As I've also said, building up, you know, community trust and engagement leaders actually assist in us to, you know, create that pathway to engage with mothers in the response of HIV prevention for those information have been shared with the mothers, and they do also support and endorse the use of the bNAbs.
Thank you very much. So now it's time to start our Meet the Expert session. And for that session, it's a pleasure to welcome Joyita Mukherjee, who is based in India. Joyita is Associate Director of Access, Research and Development at IAVI. IAVI is very much interested in access to monoclonal antibodies. In 2020, they published a report with the Wellcome Trust about increasing access to mAbs globally. And more recently, and I've put this paper in the chat, they have worked with partners such as United, MPP, on developing a viable business model, and I encourage you to look at the paper, which makes reference to a few other reports. Joyita, welcome with us today.
Thank you so much, Roger.
While we wait for question, I'm just going to throw one in. So far, we use RSV as a model. We discuss the challenge of introduction and access. In your view, what do you think can we learn from what has what is happening with RSV, and that could be applicable to HIV research strategy and access strategy.
Thanks, Roger. And thank you so much, everybody, for giving me the opportunity to be here. And I must say, wonderful presentations, both of them very enlightening. So thank you so much to both Tara and Anile. And thanks, Roger, for that question. That makes a lot of sense in order for us to introspect and just think that if we are choosing RSV as a case study, a model, what do we learn from RSV? A couple of things, and I must draw from Tara's presentation as well. What we see there is early access is something that we should absolutely focus on to start with. And that's where a lot of things come into perspective when we look at things which are in the pipeline. For example, when we look at HIV, we are still in the development process. The bNAb development, the clinical development pathway is ongoing. We are still at the stage where we are looking at products that go into the clinics. But at the same time, we must look at access pathways. And I'm glad to say that IAVI, in collaboration with different stakeholders across the globe, have already initiated some of those discussions, and they are highlighted in these sort of publications which are out there. And key to that is generating evidence, because a lot of decisions which will be based on evidence which comes in. And it's not just evidence from one angle, but what we should look at is biological evidence, clinical evidence, as well as behavioral evidence. And tied to that is very important to look at policy perspectives, rather more specifically policy openness, because it'll have a varying impact on how we are looking at these evidences from different regions across the globe. Like Anile mentioned, it's absolutely important for us to understand the community demand and the acceptability, and it'll again have varied insights from different regions. And thirdly, what we should understand is the provider perspectives, because when it comes to bNAbs, or for that matter, any new product, and particularly in the age group that we are looking at in case of infants, newborns, neonates, as in the case of RSV, and also like we see is the use case for HIV bNAbs, the way it's going to be particularly now being considered for vertical transmission, provider perspectives become extremely relevant. So a couple of things that we can draw from how RSV has moved is, again, if we look at it, for some of the early RSV maps, there was a space where we had half-lives of something like 20 days. What that means is we will need to inject the mAbs again in a reasonably shorter period of time and go in for those regular injections. And that was one of the reasons why things went for not so much of a success, and they were improved upon. So we now see a stage where we have a shot which is lasting impact for almost 5 months. And so that is something that helps us understand what is it that will work with the end users, getting a sense of that very early on. As we are in the development process, product developers being cognizant of those barriers and act on them to integrate them in the development process itself. Of course, not to mention the breadth and potency of the development. Like we see in HIV bNAbs, we are considering cocktails. We have learned that one will not work. We need a cocktail. So taking that into consideration, cost. We have to act on the cost. The problem that we see with RSV, we have things available only in higher income countries, whereas the burden exists in lower middle income countries. So right in the beginning, how do we ponder upon those strategies, those business models, those financing needs? So all of these things coming together gives us a good place to start thinking when we have a look at HIV bNAbs. And of course, also have evidence on identifying the epidemiology. Who are the high-risk vulnerable populations to whom staggered access will be given? At what point? How do we have policy decisions that are based on those? Start working with the individuals and stakeholders who can make those decisions early enough. So yeah, I mean, there are more, but I think these are some of the prominent ones that we can start with.
Thank you very much, Julieta. As Ashley said, our two presenters, Tara and Anile, if you would like to add to that, please do not hesitate and just light up your camera so I can see if you want to add to this. Okay, so while we wait for question, and please, in the audience, don't hesitate, post your question or raise your hand. I want to follow up on one of the things you said, Julieta, which is about generating evidence, which no doubt is it necessary. And you listed a range of evidence in various areas. And do you think that in that particular context of bNAb for HIV prevention for infant and newborn, it's going to be more difficult to convince policymakers because we already have effective intervention, even if we know that, you know, we are not 100% delivering on these? But does it make it more difficult? And do people tell you, well, we already have something, so why should we do that? And how do you manage that?
Right. Thanks, Roger, for that. And yes, I would draw upon a few examples of some studies that we did in an Indian context as well as in the African context. So there is a need, and the reason why I mentioned evidence was because as we are developing this, we have to be very mindful of the kind of communication that we are, you know, sort of bringing out for the end users so that it also helps them to base their decision on. That's the responsibility that we have on our side, to be able to cater and tailor the information. In that sense, the evidence should base on what is a unique value that the product that we are talking about is bringing on board. What is that unmet need, the gap that this product is helping, bridge? That's one point. The second thing is, when we are developing a certain product, it doesn't take away the need or the importance of anything else that's already existing, because that's how we also speak to the point of choice. Because one product coming doesn't make the others redundant, because at the end of the day, end users should have the right to choose whatever they feel they are comfortable with, whatever aligns with their particular personal need. They should be able to make a choice from within the diverse set of the toolbox. So these are the two things that we should be very mindful of. We did an acceptability study for HIV bNAbs in India, and from some of the insights that we have heard from the end users, and I must point out also that in India, particularly when we spoke to the pregnant mothers or nursing mothers asking about the acceptability of bNAbs for their babies, they were people who were very conscious of the fact that there was high success of PMTCT in the Indian context. But there was still existing gap. There was a leak in the pipeline. So they were still willing to accept this product for reasons that they were conscious that whatever helps them reach that 100% mark of prevention, they were willing to take it. However, they did highlight some of the notable things, that we should not be having serious side effects on the infant. And some of them did give examples of what they would think as serious. And they were very mature to even call out that we are okay to accept reasonable adverse effects or side effects, but as long as they were not severe, they were still willing to go ahead with that. So that was very encouraging. Even in the African context, we hear some of these tonalities. Yes, but as product developers, as people on the other side, it does make sense for us to think about the unique value that this product is bringing and cater our messages according to that.
Thank you. And still on the question of evidence, and in particular scientific evidence, IRV has been conducting clinical research for over 25 years and leading in many areas. Do you think that HIV presents additional challenge for bNAbs research compared to, let's say, RSV or other infection? Is there something, I wouldn't say special, but you know how the HIV field has its own specificities. But is there something that makes it more difficult to conduct the research because it's HIV?
Yeah, I think so. Maybe I know we have Glenda on the call here, so maybe she can also add to it. But I think what has uniquely been challenging for HIV, like we all know, is the diversity of how the virus presents itself, the significance of the diversity of mutations that we see. Also, not to mention, when we talk about bNAbs, what comes into picture is the latent reservoirs, because what we have seen is when it comes to bNAbs, probably the diversity, the potency can be handled by the different strategies that we have now in the making, in terms of having broad, sort of cocktail of bNAbs and all of those things. But what we are still yet to handle is the problem of latent reservoirs, where the virus goes silent, where we are not able to detect the virus. Of course, there are now strategies that people are thinking how things like, sort of active activate the latent reservoir and use that in combination with bNAbs, that's still being thought through. That is one of the strategy that people are trying to solve. But yes, because of the nature of the virus, because of the nature of how HIV is, it does pose additional challenges in the research that we have to do. But I must say that there is hope. And as advocates, when we go out on the field, it is important for us to keep up to that messaging, because there has been significant progress that has been made even in the field of HIV, whether it is bNAbs, whether it is vaccines, whether it is other prevention products. So I guess that's important for us to have as an underlying message, even when we are communicating the actual and being transparent about the challenges. So I don't know if Glenda or anybody else
I was
wants to
just
add.
asking if Glenda wants to say
sorry,
something about that.
Yeah, I mean, I think I would agree with you on everything, and maybe just to add as well, is the lack of, I guess, pharmaceutical partners, people who so I think at a global level, we lack partners that will want to commercialize bNAbs for this indication. The diversity is an issue, particularly in areas where there's recombinant HIV, and trying to make sure that the monoclonals that we choose also cover areas like West Africa and Central Africa. So I think just one of the issues that maybe also for mothers who are advocates and early is also to see whether there is a voice for of the mother that will help us advocate for these kind of interventions to control or eliminate pediatric HIV.
Thank you. If we have time, I'll come back to the question of the pharmaceutical partner. But one question related more to the acceptability of this product. Assuming that in a few years we may have bNAbs that can be used for prevention of HIV in newborn, how can we effectively communicate the benefits and the risks to parents and caregiver and enhance their acceptability and trust? We don't want to be, I guess, in the same situation with vaccine where there is a lot of vaccine hesitancy. So, and that kind of relate to my initial question: what can we do now to prepare the ground for this product to be acceptable once they will be there? Julieta, if you want to say a few words on that.
Yeah, absolutely. And that's absolutely very, very critical. And which is where I think there should also be a focus on pushing investments to have these acceptability studies right now, because sometimes we're often faced with this question that we don't yet have the product. So how can we have acceptability studies based on something which is hypothetical? But then there's the other side of the story wherein if we don't do these right now, we will land in a situation where we have the product, people are not aware of the product, they are still considering the newness of the product, they are still, sort of trying to deal with what it means as a product. So I think it's very, very important and timely to have these acceptability studies. But tied to that, the only question that should be asked is not, is it acceptable? What goes with that is giving the information of how unique the product is, how is it helping meet the unmet needs and bridging the gap, and also then adequately telling them, informing them, educating them, and co-creating strategies to be able to tread that path with the end users to say that, yes, this is something which is coming up, but from now till when it is there, these are the things that, sort of you should know, you should join hands with the researchers and the product developers and help advocate for the community that you represent. So that's something that is absolutely necessary. So acceptability studies, again, referring to the one that we had done in India, it was a great success because we got to know from the end users that they were very open to such a product. The only information that they were asking was, help us understand what does it mean and help us understand what the side effects will be. And we are willing to take that path, to decide and to adopt this if it is there. So that was very encouraging. So again, push and voice for more investments to have these acceptability studies and make that information available.
Thank you, and that nicely bridges my question I kept in reserve, which was about what Glenda said about the need to partner with pharmaceutical industry, but thinking again long term, where are the manufacturer? How are we going to address the issue of manufacturing? And there's a big push to strengthen capacity building for manufacturing in low-income countries, and there is a lot of work done on that. But in line with IIV's work, how do you see bringing these people on board, pharmaceutical industry, manufacturer?
Yeah, so I'll just like to add there that you see, the manufacturing issue is not just unique to HIV bNAbs, but in general, right now, as we speak globally, there has to be a broader focus on, sort of affordable manufacturing for monoclonal antibodies. And that sort of has become an interest which has made it a central policy sort of issue in more than one countries, particularly in the LMIC. So we should have strategic discussions to see, like the paper which we've shared, Roger, from IIV as well, along with other partners, the deliberations there focus on what kind of new business models that we can have, what kind of financing and investment strategies that we should look at, because what exists is not working for the kind of problem that we have at hand. So we need to diversify. We need to see what kind of newer models can be there. Tech transfer is one of the things that was a highlight in that paper. There needs to be a technology transfer so that we have more push, more sort of voices for shifting the manufacturing to LMICs, so that there is indigenous manufacturing in the African subcontinent, indigenous manufacturing in India, so that once we push indigenous manufacturing, local manufacturing, there will have to be an impact on the affordability. And that is what perhaps brings the feasibility aspect to a more, sort of from something which is absolutely distant to something which is a little more near future, and perhaps help bridge some of the existing problems. I don't know if Tara or anybody else wants to add to that.
No, thank you so much, Joita. Tara, anyone else to add? No?
No, I was just going to say that that was really well put, and I do think exactly that. I think we just need to be realistic and cognizant of sort of how the commercial side of things work and those business models and the incentives, as well as the risks, and then understand how we as global health partners can support sort of, risk sharing, and also make sure that we make investments where the global health impact is greater than what the current sort of product, let's say, availability or access is. So that's really key. Thanks.
All right, thank you so much for sharing what can be done, what needs to be done to make this successful. Before I introduce our next speaker, I would really like to encourage our audience once more to be proactive and to ask questions. And with that, I would like to introduce Caitlin Blackdale. She's an infectious disease physician and also an assistant professor at Harvard Medical School. And she will talk to us about cost effectiveness and policy implications. Over to you, Caitlin.
Great, thanks so much. I'm going to go ahead and share my slides. Okay, are those coming through?
Yes.
Okay, great. So I'm very pleased to present this analysis on behalf of a large team of investigators from USAID and IAVI, as well as Mass General Hospital, where I'm based. And I'll be presenting our analysis on the cost effectiveness of broadly neutralizing antibodies for infant HIV prophylaxis in settings with high HIV burdens. And I have no disclosures. So as we've been discussing across both of these webinars, broadly neutralizing antibodies, or bNAbs, could supplement existing infant HIV prevention approaches, could help fill those gaps that were just alluded to in the last presentation. But despite continued expansion of efforts to prevent vertical HIV transmission, an estimated 130,000 children acquire HIV each year. And approximately 2/3 of these children have mothers who are living with undetected HIV at delivery or acute HIV while breastfeeding, and therefore are not protected by existing prevention efforts which target children who are known to be HIV exposed. So if the babies are not known to be HIV exposed, we currently don't have any approaches to help protect them throughout the breastfeeding period. bNAbs have demonstrated efficacy against perinatal and postnatal HIV acquisition in non-human primates, prevention of acquisition of bNAb-sensitive virus in adults, and safety and tolerability when given as injections to newborn infants. Our objective was to estimate the potential clinical impact and cost effectiveness of offering bNAb HIV prophylaxis to infants born in 3 country settings, reflecting various HIV epidemic characteristics. And for this analysis, we chose Côte d'Ivoire, Zimbabwe, and South Africa. We used the cost effectiveness of preventing AIDS complications, or CPAC, computer-based simulation model to simulate individual infants from birth to death. And CPAC accounts for vertical HIV transmission risks and pediatric HIV prophylaxis, diagnosis, and treatment. And if you're interested in how the model works or what the features of the model are, you can check out more detailed specification available online at the QR code on the right. In terms of the modeled strategies, we first modeled a standard of care strategy, which we abbreviate as SOC, where infants with known HIV exposure were offered WHO-recommended oral antiretroviral prophylaxis. We then modeled offering bNAbs to one of 3 target populations. First, bNAbs could be given only to infants with known high-risk HIV exposure. We abbreviated that strategy as HR-HIV. Next, shown in blue, we modeled a strategy of bNAbs given to all infants with known HIV exposure, abbreviated as HIV. And last, in purple, we modeled a strategy where bNAbs were given to all infants irrespective of known HIV exposure, akin to a vaccine, and we abbreviated that strategy as all. Infants in the bNAb target population were then offered one of 3 dosing approaches for the bNAbs, and all of these dosing approaches were offered in addition to the existing standard of care or WHO-recommended oral antiretroviral prophylaxis. So in the 1-dose strategy, infants received 1 dose of bNAbs at birth. In the 2-dose strategy, infants received a dose of bNAbs at birth and then again at 3 months. And in the extended dosing strategy, infants began bNAbs at birth, and bNAbs were continued every 3 months thereafter for up to 18 months while they were breastfeeding. And we evaluated all combinations of target populations and dosing approaches, which led to a very large number of combinations, a very large number of strategies evaluated. In terms of our key model inputs, we modeled a maternal HIV prevalence at delivery of 3% in Côte d'Ivoire, 12% in Zimbabwe, and considerably higher in South Africa at 33%. And these were informed by FIA data and antenatal surveys, as well as other published literature. We modeled maternal knowledge of HIV status, ART uptake, maternal HIV incidence, and HIV-related care costs, all based on country-specific data from UNAIDS estimates, DHS data, and other published sources. In terms of our bNAb input parameters, we modeled bNAb efficacy against intrapartum and postnatal HIV acquisition of 70%, and this assumption was based on efficacy against sensitive virus in adults from the AMP study and published data on neutralization coverage of single bNAbs as of 2022. We modeled an effect duration of 3 months based on impact study PK data and a cost per dose of bNAbs of $20 per dose. And this cost is intended to reflect the estimated costs of monoclonal antibody production and vaccine delivery or implementation in low and middle income countries. In terms of modeled outcomes, we projected the total vertical HIV transmission rates and incremental cost effectiveness ratios, or ICERs, in US dollars per year of life saved. We considered a strategy cost effective if it resulted in the greatest projected clinical benefit and was cost saving or had an ICER of less than or equal to 50% of a country's annual GDP per capita. And given the number of strategies, we only present results of the strategies that were non-dominated by other strategies. so that were either more beneficial and less costly than another strategy, or were more beneficial than a strategy with a lower ICER, basically offering better bang for the buck. Now we'll turn to our results. In general, we found that bNAb strategies were projected to be cost-effective and to reduce HIV transmission by 24 to 43%. So in the standard of care approach, using only oral antiretroviral prophylaxis, we projected total vertical transmission of 8.4% in Côte d'Ivoire, 9.5% in Zimbabwe, and 4.4% in South Africa. With strategies that added broadly neutralizing antibodies from birth, total projected vertical HIV transmission was decreased, as you can see in kind of each of the subsequent lines in the table, and resulted in a net increase in projected life expectancy for the population. We found that a strategy of offering all infants who are known to be HIV exposed bNAbs from birth and throughout the breastfeeding period would actually be cost saving in all 3 countries, as shown here in green. And that cost saving came from the fact that there were infant HIV infections that were averted through the use of bNAbs. And so that whole lifetime of costs that come with HIV related care for babies who are infected early in life was prevented by using bNAbs to reduce overall vertical transmission. In Côte d'Ivoire and in Zimbabwe, that strategy, hive extended, of giving infants who are known to be HIV exposed bNAbs from birth throughout the breastfeeding period, was not only cost saving, it was the cost effective strategy, meaning that it had the best value while still maintaining an ICER less than 50% GDP per capita, which was our pre-established cost effectiveness threshold. The more intensive bNAb strategies, as shown in red, were not cost effective in those settings where prevalence is lower than in South Africa, because the ICER was above that pre-established threshold. In South Africa, in contrast, we found that a strategy of giving all infants, irrespective of known HIV exposure, bNAbs from birth throughout breastfeeding was cost effective, with an ICER of $882 per year of life saved. And that was really driven by the fact that maternal HIV prevalence is much higher in South Africa than in the other settings. We also found that bNAb infant prophylaxis would remain cost-effective across a wide range of efficacies and costs. And so here, I think it's really important to highlight that we don't yet know what the cost of the final bNAb product that would be implemented would be, nor do we know its efficacy. We have some sense from the pilot studies that have been done thus far with available bNAbs, but as bNAbs are packaged into combinations, the efficacy and costs may change. And so we wanted to look at how would a range of different costs and a range of different efficacies impact the potential cost effectiveness of using this sort of approach. So in Côte d'Ivoire, as seen on the left, where maternal HIV prevalence was modeled as 3%, we varied bNAb cost from $5 to $100 on the y-axis, and we varied bNAb efficacy from 10% to 100% along the x-axis. The white X in the middle at the intersection of $20 cost and 70% efficacy reflects our base case. What we can see is that in the vast majority of plausible combinations of bNAb cost and efficacy, the cost-effective strategy, as shown in dark blue, was to offer infants who are known to be HIV exposed bNAbs from birth throughout breastfeeding. As we move to Zimbabwe in the middle, where we modeled a maternal HIV prevalence of 12%, that same strategy was cost-effective in the base case, offering bNAbs to infants who are known to be HIV exposed and continuing that throughout breastfeeding. However, we found that if bNAb costs were substantially lower than projected in our base case at $5 or $10 per dose, and bNAb efficacy were higher than our base case estimates, then there were strategies that became cost-effective in which you could offer bNAbs to all infants irrespective of known HIV exposure. Lastly, as we move to South Africa on the right, where maternal HIV prevalence was modeled as 33%, we found that for the majority of combinations of cost and efficacy, a strategy of offering all infants, irrespective of known HIV exposure, bNAbs from birth throughout breastfeeding was cost effective, and that's what's shown in this purple. So even if bNAb efficacy were not quite as good as what we modeled in the base case, or if costs were slightly higher at $40, even $60 per dose, we found that that strategy was still cost effective. Our analysis has a number of limitations. Most importantly, the characteristics of bNAb infant prophylaxis in actual clinical settings remain unknown. However, bNAbs are projected to provide good value throughout plausible efficacy and cost ranges. We also did not explicitly consider health equity in this analysis, and the cost-effective bNAb implementation approach may differ depending on equity considerations, one's cost-effectiveness threshold, and levels of partner funding to help support bNAb rollout. In conclusion, we found that offering bNAbs to infants with known HIV exposure would be cost-effective in Cote d'Ivoire and Zimbabwe, and offering bNAbs to all infants would be cost-effective in South Africa, where maternal HIV prevalence and incidence are relatively higher. Cost-effective bNAb strategies would substantially reduce projected vertical transmission compared to the current standard of care, and the potential clinical impact and cost effectiveness of bNAb infant prophylaxis should motivate further bNAb research and development. I'd like to acknowledge our other study team members as well as our funders who are listed below. Thank you.
Thank you, Caitlin. It's time for Q&A. Dearest audience, please don't be shy. Do you have any questions on cost effectiveness?
I'm going to wait a little bit, and just a reminder for presenter audience is made of a range of alumni from the enterprise and from the Cure Academy, and many of them are early career researcher or maybe mid-career researcher. So please do not hesitate, and I really encourage you to go ahead and ask a question. There is no stupid question. I'm going to start with a stupid question. To make sure that I understood that well, Caitlin. So what you're saying is that we don't need to know the HIV status of the newborn. It is still cost effective to use bNAbs.
Yes.
And there's another side of that coin, which is, what if the newborn has acquired HIV? So
yeah. So when I'm kind of talking about strategies targeting infants who are known to be HIV exposed or not known to be HIV exposed, I'm really talking about the status of the mother. And so there are situations in, based on maternal HIV incidence and prevalence, where it would be most cost effective to focus only on the babies who are known to be exposed to where the mom is known to be living with HIV. However, when maternal HIV prevalence gets to be very high, the cost-effective strategy turns to being more like rolling out a vaccine for everybody, irrespective of whether an infant's mother is known to be HIV exposed or not. In terms of the baby's HIV status, we did model infants who were living with HIV from birth and throughout breastfeeding, and we did so with kind of country level estimates of their current rates of infant diagnostic testing. If an infant was recognized as living with HIV throughout the breastfeeding period, then they were taken off of bNAbs and started on antiretroviral therapy as per standard of care. But even with gaps in that testing cascade as exist right now, we still found that bNAbs would be cost effective. And that cost effectiveness would likely only increase, assuming that bNAbs would have some protective efficacy on the baby, and some efficacy even against HIV viral transmission if HIV were acquired by the baby while they were receiving bNAbs.
thank you. So I've got a follow-up question, but I will put the question we have from the audience, from Oba, who's asking, I've lost the question. I guess he's asking that in your cost effectiveness calculation, do you account for the possible impact of HIV subtype and therefore the efficacy of bNAbs that may vary from one country? And I guess it's a good question being from West Africa to Southern Africa. How could that affect your calculation?
It's a really good question. And, the actual efficacy of a final bNAb product against HIV subtypes is unknown. What we did was look at in vitro data of a variety of different subtypes and different single agent bNAbs against those to be able to inform the range of efficacy that we looked at. And so while in a given context, bNAb efficacy could be less than the 70% that we assumed in the base case, let's say it's only 50% effective against a given subtype, we still found that 50% efficacy across all three settings that we looked at would provide good value. So we tried to capture that by looking at such a broad range of efficacies, because we won't know until we have a final product to be able to test against the different subtypes.
Thank you. I've got a follow-up question, which in fact, I already saw your presentation in June. I was very surprised at the time. So I'm going to be surprised again for this audience. Said, oh my God, are you saying that even with a product that is 10 to 20% efficacious, as long as it costs $10 to $15, it is still cost effective? And for people to really understand, we're talking about a product which is very, very not very good, but it's, well, let's say you call it cat, and it's still cost effective. Is that correct way of saying some of what you said?
Yeah. So if you have a not very good product, but that's not very expensive, it still offers good value, because the costs and clinical consequences of a lifetime of HIV infection are enormous. And so if you can prevent even a small number of transmissions to infants very early in life with a product that might not be as good as we all want it to be, it can still provide good value. It really depends on that intersection of how good it is, how effective it is, and how much it costs.
Okay, I'm going to bring Joyeta back in if you are here. Joyeta, that's quite a very powerful argument from a policy and business development perspective. What do you think, if you're still around? I'm not sure if Joyeta is still with us. Or Tara, maybe from a different place. Oh, Glenda. I've got 3 names on my screen. If someone wants to comment on what the potential impact of that result?
Well, I think it's got to do with scale. So you can have a low efficacious intervention with saturation of all infants. We heard that in South Africa, it's women that are acute seroconversions, or that seroconvert during breastfeeding, are not picked up by the normal screening processes, and are likely to transmit, because obviously they'll have a high viral load. So if we could give, say in South Africa, if we could give these interventions to all babies at birth, and that means you go to scale. So there's 1 million kids that are born in South Africa. If we go to scale and we saturate all the infants that are born, then we can really work on eliminating that last bit of HIV in South Africa. And it also then preserves breastfeeding, because that these bNAbs are developed for us so that we can also protect in the breastfeeding period. And so I think it has huge implications for maintaining breastfeeding, and for if we give it to all women, it will destigmatize the interventions, and it doesn't necessarily identify a person living with HIV, but basically gives it like BCG at birth, gives it to all babies.
And how do you think, I know policymaker and Ministry of Health, you work with these people, how do you think they would react to this statement, even if it's only 20% efficacious, you will save money? Is that something they'll buy in?
Well, it's unlikely only to be 20% efficacious, because if we're going to be using 2 or 3 bNAbs that cover, when we look at the PK levels, it's highly unlikely. We're going to be seeing efficacy of 70% and above. So the 20% is not likely, and particularly in a clade C area where the monoclonals we're looking at have got broad coverage and quite a lot of potency. And with the LS mutations which have made these monoclonals long acting, it's unlikely that we're going to see such low levels of efficacy. For me, it's a Minister of Health would want an intervention that's easy to give. And if you could give an intervention to every baby that's born, that's much easier than trying to figure out who is or isn't living with HIV, whose baby should get it. So I think it's much easier to give it to all babies, and it's probably going to be a lot more efficacious than 20%.
Thank you. It was very academic in terms of, when you see the result, it's so surprising. We have a question from Sabdat Ekama, if you want to come online.
Yes, thank you. Thank you, Kathleen, and all other previous presenters for the insightful presentations. I just wanted to find out what the storage temperature requirement of these bNAbs might be, and also what the shelf life is like. Because at the end of the day, if it requires stringent temperature requirements, I don't know, it might impact its use and widespread use across other countries with varying climates. And also from the experience of the COVID-19 vaccines, if it has a short shelf life, also will have issues with wastage and all that. So I was just curious. I don't know, any of the presenters, is not really directed at Kathleen, any of the presenters could help answer this question. Thank you.
Thank you. So storage temperature and expected shelf life of bNAbs. Anyone wants to take that technical question? If there is someone in the audience who has a ready answer.
Well, I think that the ultimate target product profile will need to have some of those characteristics. At this moment in time, what we're trying to do is develop the proof of concept that will take us across to a product that could be commercialized. But we would draw on the experience from other monoclonals, and it'll hopefully it'll have the same kind of characteristics as we see in RSV. There's a possibility that that there will be minimal cold chain. It's not going to be -80, but the kind of cold chain that we expect for any childhood vaccination. So that's what one would work for. And I think once you've got proof of concept, the innovation in making the product viable for all parts of Africa will be the next step. And it'll be developed based on the experience of other monoclonals and biologicals that are used in parts of Africa that are remote as well.
Thank you, Glenda, and I can see from
Thank you.
From RSV that the Beyfortus product can be stored at room temperature, protected from light for a maximum of for it doesn't say the time, but it says it seems to be a variable. But again, otherwise it's stored in I would say fridge temperature. But again, it's part of the target product profile. I'm going to hand over to unless there's another question. Check in the chat. If there's another question. No, I'm going to go over back to you, Ashley.
Thank you, Caitlin, for this presentation. I mean, Roger pretended to be surprised. I am very surprised. So apart from these technical aspects, we already heard from Enele how important perception of bNAbs is for implementation. And on that note, I would like to introduce our next speaker, Laurette Bukasa from the University College London, and she will talk to us about amplifying community voices and how to meaningfully involve them in research and beyond. Over to you.
Thank you, Ashley, for the introduction, and thank you all for the invitation to speak here today. I'm just going to share my screen. A second. Share. Is that okay? Can everyone see that?
Yes.
Okay, awesome. So let me minimize this. Okay, great. So as Ashley mentioned, I'm going to be speaking about my experiences with involving the community, specifically mothers living with HIV in my research. So a little bit about me first. Sorry, give me a second. So I'm a doctoral student, recently finished, completed my Viva at UCL, and my thesis was on children born HIV-free. So children born to women living with HIV, but who are uninfected themselves. And I was using population level data from national surveillance based on the screening program that we have there in pregnancy. And as part of my project, I really wanted to do a public engagement, patient public involvement project to understand a little bit about what mothers thought about my research and what their priorities were. But I will discuss more of that shortly. First, I want to talk about what patient and public involvement is and why it's important. So PPI describes activities and approaches where researchers and the public interact to share knowledge with the goal of generating mutual benefit. Now, PPI activity has increased significantly in the UK, with a movement really led by national stakeholders, including the leading research funding institution there, the National Institute for Health Research. And this is really to push involvement from communities and service users in decision-making about research and policies and policy implementation. This is because we know that PPI increases relevance and impacts of research and policy, and it builds trust with the community and rebalances power. So inform is the lowest level of PPI that you can do, and it involves just making the public aware of the research that you're doing. Next level up, slightly better, is consulting, and that's where you're informing and engaging the public through meaningful encounters where their opinions can influence the trajectory of a research project or a policy. And the best form of PPI is collaborate. So this often comes in the form of patient advisory groups, co-designing and co-producing research with participation from communities from the start. So moving from inform to collaborate, we increase the relevancy of research, and rebalancing that power dynamic is really important, as researchers are the curators of knowledge in general, and we need to acknowledge through actions the expertise of lived experiences. So what does meaningful involvement of the community look like? So what it means to me is contribution with impact. So approaching PPI as a researcher willing to learn, having very clear objectives and related pathways for contribution that will enable participants to feel empowered. Adequate remuneration for time and expertise. The public are often volunteering their time away from their lives, and this should be recognized formally and in a tangible way. And it is a tangible way for researchers and policymakers to show that they recognize the value of their contribution. And a partnership with community representatives, I feel, is really central to this. They're essential for building trust between researchers and policymakers and the public, as we are not necessarily embedded in the community. And by partnering, we're able to learn from these organizations and facilitate a safe space for open conversation. So speaking a bit more about my own experiences, I wanted to incorporate all of the elements that I aforementioned in the previous slide when planning my own project. And so for my project, I wanted to increase knowledge and awareness of the surveillance that was happening, the data that we were collecting, and the research on pregnancies to women living with HIV as it relates to children born HIV-free in the UK. I also wanted to enable women living with HIV to provide feedback and contribute to the research and possible future engagement activities on children born HIV-free. So how I went about it, I formed a partnership with 4mNet, who are a national community-based peer support network for mothers living with HIV in the UK and actually in East Africa. And I applied for internal funding to pay them as collaborators, so the organisation themselves and the participants for their time. Funds were also used to pay for materials and data bundles to enable access for these mothers to be able to join the online workshops. So this organisation was selected because of their principles, putting women first, and as the predominantly primary caregivers of children born HIV-free, I felt that they were a particularly important group to engage with. So we co-designed 2 online workshops over 2 consecutive Monday evenings that were highly interactive, using a combination of online tools, and also created a safe space for open discussion. The exercises that we did during the workshops included a combination of ranking exercises, interactive polls, and open-ended discussions. So the content of the workshops were focused on discussing my research plan and the wider research area, with one exercise including guided discussions with the women's wider networks if they felt comfortable to do so, which I will talk a bit about shortly. We also, a key, I guess, approach for the way that we did this is that we split the moderation of the discussion, which allowed me to observe and take lead from the organisation representative on how to navigate these conversations that were often quite sensitive. I came to the space as a student, to their life experiences and priorities for their children and their families. It was also empowering for the women that participated, as my co-facilitator was also a mother living with HIV. So there was an implicit understanding of their experiences that validated their contribution to the workshop. As part of my activities, I designed a booklet to support the workshops, which I sent to all participants prior to the first workshop. And it was the main aim of it was to record their reflections of the participants that may not have been shared within the group for whatever reason. So here is just a screenshot of some of 2 pages of the booklet. So you can see here that I included prompts and visual representations to make the booklet more engaging for women. But reflecting on it now, I think the real value of it is that it allowed women to have a confidential space where they could record their thoughts, which can sometimes be difficult to raise in a group setting. And after the conclusion of our workshops, I asked the women to send the booklets back to me so that their views could be included in the write-up and the action plan. So as I mentioned, one of the tasks between the workshops was that I asked women to go and have conversations with their wider network if they felt comfortable, and they did talk to other mothers, their family members, and even their children, which I think this is something that Anele touched on earlier in the webinar. So this approach really led to an unintended or indirect benefit of facilitating these conversations around children born HIV-free that were never had before within communities. And a really positive piece of feedback from this task was that it provided an opening for mothers to have this kind of conversation with their children born HIV-free, which they never had before. And it yielded some really interesting results, with some children feeling like that they were not different and that they didn't want to be treated as such, whilst others could understand how their context differed to other children based on other factors, social and economic factors that really closely correlated with HIV status in the UK. So this highlighted to me that it's important to have representation across key groups in the community, as views on research and policy implementation may differ. So some of these children had very different views from their mothers about what was important and why it was important. But this, of course, may make it much harder to align a single approach when thinking about particular research questions and strategies for implementing policies. But at least I think that there is an overall benefit still, because there will be an awareness of barriers and limitations prior to initiating that research or that policy. So some conclusions. what I've learned from this project is that women and communities have an appetite for research and have views on how they should be involved. What was of interest scientifically to me was not necessarily aligned with the priorities of the mothers, which really, for me, highlighted the value of this work. I've learned that working with an organization embedded in the community is instrumental to the quality of work that's produced, particularly when dealing with sensitive topics and navigating stigma. Their input was invaluable in facilitating that safe space for these discussions to take place without creating anxiety. This experience has been incredibly beneficial for me, both as a researcher and the women who participated. And a heartening part of the feedback I received was that all of the mothers felt like the experience taught them more about the research area, made them feel more confident in speaking about it, and even in participating in research as a partner in the future. So PPI with real partner organizations can make your research better and you a better researcher. Thinking about how these learnings can be applied to research and policy implementation of bNAbs, I have two key considerations. The first is to adopt the collaborate approach and co-design research with communities that will be targeted when scaling bNAbs as a prevention for vertical transmission intervention. I think doing this will be invaluable for research and future policy planning. And the second is that a woman-based approach may be beneficial. They are often the primary caregivers and they have important views on the health of their children, how to safeguard it, and potential barriers to adhering to treatment protocol. And with that, I thank you all for listening and invite questions from the floor.
Thank you so much, Lorette, for sharing your insights, the lessons learned, also on how to implement those. And I'll hand over to Roger.
Thank you, Lorette. Before we go into the mid-expert session, we have a couple of minutes, and I'll ask a question. I mean, community involvement and participation in research has been discussed for a long time, and I posted a link to an EVAC and UNAIDS work on how to involve communities in clinical research. In your view, one of the questions has always been when to start involving community in the design of the research. If you listen to the scientists, I'm one of them, previously in a former life, it's not too early, it's complicated. And if you also ask to me as an advocate, and the other one said, no, it's never too late. So in your view?
Yeah, look, it can be complicated. My personal experience was, again, complicated. A lot of my PhD was like predetermined. Limitations of the data, governance issues. So the scope of what I could look at was pretty limited. And nevertheless, though, I still felt it was valuable to have those conversations because from that, we managed to write a paper talking about a research agenda for the wider research area, and it informs a program of research. So yes, I could not address much of their concerns in my initial study, but it allows me and other researchers to guide their research questions based on what is going to have the highest impact for real life. And I think sometimes as scientists, we get very obsessed with the ideas that we have, and there can sometimes be, from the perspective of the community, a disconnect from what we feel is really important to what is really important to them. So my answer to that is really as early as possible, even if in your present project you're not able to fully address their views, it can help guide future research projects.
Thank you very much. So again, we now are starting the Meet the Experts discussion, and our two experts, plus of course Lorette and Caitlin, are welcome to join. Carmen Perez Casas, who is a senior lead for strategy at United. Carmen works on identifying and supporting intervention to surmount access barrier, to best option for treatment, diagnosis, or prevention or major disease affecting low and middle-income countries. And we also have Glenda Gray, who is one of the principal investigators of the Brilliant Consortium, which is a USAID-funded consortium working on the development of an HIV vaccine by African researchers. amongst many other positions. Glenda is very well known. She's the former CEO and president of the South African MRC. And I found out today, I think I forgot about that, that in 2014, you were recognized as one of the 100 most influential people of the century by Times Magazine. I'd forgotten about that. So welcome to Carmen and Glenda. And my first question, and we'll have question about cost effectiveness, about community participation. And again, I encourage people to put their question, is beyond cost effectiveness, what are other factors that should be considered in public health decision making, particularly when introducing new disease prevention technology? So if Carmen wants to start, then Glenda, or vice versa.
Sure. First, thank you for inviting for this meeting. I was also just to share good news for those working in prevention of HIV. I just read while we were in this webinar the news from Gilead's results of Purpose 2. So that's to celebrate its very good results as well for the other populations that weren't included in the first trial. So outside of the young women and girls is really good as well, although the access strategy that they have communicated is not so satisfactory as we wanted. So let's try to advocate again for changing that, because there is a lot of hope on this product. And from Unit 8, of course, we also have a lot of hope on monoclonal antibodies as well, to come back to the theme of today, to change also the paradigm on many of the diseases we care for, including for sure for babies and for other populations in HIV. I like very much some of the things that have been discussed before in this last session of this afternoon, including the fact that antibodies might be really, we need to explain, and you made a very good question before, Roger, if I may say, we need to explain to governments, and that's also very important related to cost effectiveness questions you have, and to donors, basically to scale up donors, that antibodies are another piece of the armamentarium. Yes, they are not going to resolve all problems. They are not maybe needed in every circumstance, but we know that there are populations for which targets are not advancing. We are not seeing any progress with the current tools we have. So we need new tools. And that is, for example, what happens with the numbers that we saw at the beginning of this afternoon with the persistent infections among babies, despite the fact that we have other tools. So for sure, I think that's an important message in terms of your first question on what other factors should be considered. Is not only cost effectiveness, it's actually uptake of the products you have. You might have a perfect product, but if it's not suited to the population that is required, it will not work. And we have to do the effort, to make the effort, to look attentively at this stage of the pandemic of HIV on population-tailored responses. And without that, we will not progress, we will not change what we are seeing. And I think as well, the problem beyond cost effectiveness is a lot of unknowns in antibodies, no? First of all, as in the report that you quoted from IABI a long time ago already, but it's still the same number. There is only 1% of the products, the antibodies that are commercialized that are in Africa, for example. So there is no experience, there is zero experience on using antibodies for whatever disease. So we don't have that, we need to make an effort on how we are gonna how can we get the best information on how to integrate these products into the countries' programs and countries' logistics and countries' procurement plans. Of course, we can learn from others, and I can come back to that in a bit later with the other questions. But we have long-acting pre-exposure prophylaxis, for example. We can learn for that for other populations. We have experience, for example, in Unit 8, we have supported a number of projects to use cabotegravir, already long-acting injectable, therefore quite close in terms of the needs, in terms of logistics, than the antibody. And there are a lot of cross-learnings, but there will be particularities. We can learn as well for infant and prophylaxis, like from the respiratory syncytial virus, but we haven't yet seen any uptake in low- and middle-income countries. And finally, other things have already been mentioned. Beyond cost effectiveness, we need to take into account user preferences and the reality For example, in Mumbai earlier this year, in a respiratory syncytial virus summit, there was a discussion and reports that, for example, there is a finite amount of vaccines that mothers will be willing to give to their kids. So if antibodies for broadly neutralized antibodies for HIV prevention are considered the same because they are injectable, they are seen by the mothers as the same, will that impact, for example, the rollout of that antibody? Let me stop here. Thank you.
Thank you. Glenda, would you like to add about what else should we look at from your perspective in South Africa?
Yeah, I mean, I think what was profound about the work that's been presented, it was not only found to be cost effective, but in fact cost savings, which means you actually, by doing the intervention, you save money, which is different to just being cost effective. It means that rolling out an intervention saves money, and that's an important thing. And so I think in terms of consideration, rolling out, governments and treasuries look at best buys. And so when there's a whole lot of new interventions coming into a country, they will juggle, they will discuss whether it's more important to get the RSV vaccine antibody or something like this. And I guess the cost effectiveness studies will be important. And if you can show that your product is cost saving, that really will take it to the top of the list. But what's important, I guess, is the rollout. And, something that's a best buy needs to be easy to scale up. And that's why in South Africa, we favor giving every infant every infant would be able to get the monoclonal antibody because it'll just be easier to take it to scale. It'll be given at the same time as a BCG, and so so uptake is likely to be good. So we do need these kind of interventions to control or eliminate pediatric HIV. This will be our last mile. We heard 130,000 infections, and probably a lot of those are happening in Eastern South Africa, and I think around around almost half, just under half, would be from South Africa. So it behoves us to find an intervention that's going to basically close the loop. If we are committed to ending HIV or controlling HIV in 2030, we need tools that can get us there, and bNAb would be a tool that could help us at least control pediatric HIV, which is kind of the lowest hanging fruit in our endeavors. So I think it's an important thing for me. Having an intervention that can give them at birth makes it scalable and makes it usable, because we do give things to infants at birth. So this would be part of the package there. The nurses are already there. The cold chain is already there. And so all you need is the product. And so I think that it would be it would be a compelling intervention to bring into the antenatal, into the labor ward or into early infancy. So I think that, so I would say this is a best buy, and it's our job as advocates, as scientists, as people that as pediatricians to make sure that the treasuries, the Treasury Department, and the people who work on the essential medicines list, both at WHO and in the regions, make sure that these kind of interventions become part of the essential medicine list. Because once it's on the essential medicine list, it makes it much more easier to get tenders and to do the processes. But what's very important, as previously mentioned, is just the lack of manufacturing capability in Africa, and we do need to find ways of finding ways to make sure we manufacture in Africa. That we basically, there are incentives. That is not, that we find ways that making products in South Africa or in Africa, there's no trade barriers, and that if we do find an African manufacturer, is that volumes are guaranteed for distribution, and that might be an incentive to get people involved.
Thank you. We listed and we discussed a number of stakeholders who play a role in access and introduction and implementation of product. And I'm glad Carmen mentioned the word donors, because it wasn't in my next question actually. And we are lucky to have one of the donor who is supporting the brilliant consortium, USAID, with Lizine on the call. And I wanted to ask Lizine, what do you think the role of the donor is in the research and development and the access?
Well, I think, thank you very much for the question, Roger. I think, as many of the speakers before me alluded to, it's so multidimensional. There are so many aspects to not just research and development aspect of developing bNAb, but also ensuring its effective implementation. And I see the donor's role as one of a liaison between the researchers in terms of creating the evidence base needed to demonstrate the value proposition of bNAbs, between the researchers and the manufacturers, the pharmacy, which is a critical point, as Glenda mentioned several times. I think that's a major gap which we need to figure out how to support the connection between at least these two pieces and the spectrum in between. Certainly, the support of donors is critical in ensuring the development of a product, but there comes a point where there just isn't enough funding to do it all alone, you know, and so bringing in private sector as soon as possible and ensuring their support is critical.
Thank you very much, Lizine. Time is flying, and I've got 3 minutes, and I'd like to end with a question related to communities, because as we heard, that's really central for the progression of research, for the acceptability of the tool being developed. And if Carmen and Glenda can first comment, and if we have time for that to comment, is how can we ensure that community voice and needs are genuinely integrated into the policy-making process and into the research? And really short answer, like 1 minute.
So I had a number of, I had a number of elements I was planning to share, but let me pick up one that I think it will be maybe the most important from all of them, is resources. We have in our experience seen communities flourishing and communities being extremely important in, for example, antiretroviral optimization, in, for example, PrEP and everything, because actually part of it is because we have funded work, including the community's work. So when we fund a research and development project, when we fund as donors an implementation project, we request that communities are engaged and that they receive sources as well, so that they can actually be really fully committed, engaged, and participate. And therefore, this has been changing a lot of the possibilities that we can find. So to me, one key element for ensuring community engagement is fruitful is to provide them with the resources they need to do so, because they are extremely capable. Is sometimes limited to that factor of not having the possibility to do it. Thank you.
Thank you. Glenda, how do we ensure community voice are
Yeah.
heard?
I mean, to add, I think we have to use, so communities are very important, and they should be like lobby groups. They should be lobbying the African Union. They should be lobbying the government. You know, so we need to make sure that we use that activists and communities see the importance of trying to address a disease and work together to lobby groups to influence change. We've seen it happen before. The treatment action campaign with the rolling out of nevirapine to pregnant women was done because of patient activism. So I think we have to make sure that we learn how to strategically work together, scientists, advocates, activists, and community to realize these kind of opportunities to try and force change at a government level. This is a political decision. You know, we not only do we need the private sector, we need the governments to commit to public manufacturing capabilities, like we see in Brazil with vaccines. You know, we need public funds to go into manufacturing actually on the African continent.
Thank you. You broke a bit in the last word, but I think we got the message. Laurette, final word.
Thank you, Roger. I think it's got to have buy-in from all the stakeholders.
I'll let you with a minute.
You've got to have buy-in from all the stakeholders. You've got the governments, the research community, the community themselves. There has to be that belief, really, that the community voices are valuable, and having a real solid plan and objective for how to incorporate their beliefs into how you plan your research projects and your policy implementation. So it's got to have, that's the main message, buy-in from all of the stakeholders to be able to facilitate this involvement from communities.
Thank you, and thank you to Carmen and Glenda. I'm handing over back to Ashley.
Thank you.
Thank you so much. Time was indeed flying. Thank you to our audience who stayed with us. Thank you for our presenters and the experts for taking the time and explaining the topic. Thank you, the moderator, for the so thoughtful question. And as I said, the recording will be uploaded on our IAS Plus channel for educational purposes. And with that, I wish you a very beautiful weekend, and thank you again.